Well, hello, human biology class. It's been a little while since I've done this, so here we go again. So this is for Friday's class, and so hopefully I got that email out to everybody. This is an image that we kind of left off with on Wednesday, and I wanted to pick it up there. We talked about the different types of pathogens, and this is not an all-inclusive list, but these are simply some examples. And this tapeworm one, this is kind of an interesting one. My wife had an elderly lady as a patient one time, and her prognosis or diagnosis was simply failure to thrive. That's all it says, failure to thrive. That's kind of like in the health professions. If they don't know what's doing it, they'll say that, failure to thrive. Don't know what it is. So she was taking care of her, and she and the aide were cleaning her up one time, and my wife noticed a little square white segment on her bottom end. And immediately had a suspicion about what that was and passed it on to the doctor. And it seems that the reason the lady was failing to thrive was because she had a tapeworm in her. And that was hopefully, she didn't really know what happened after she cared for her that time, but hopefully she was treated for that and her condition improved. But yeah, that's a tapeworm. Again, typically you get those fecal oral. So somebody goes to the bathroom that has a tapeworm, gets a segment on their hand, didn't clean their hands really well, and somehow you contact that segment, and away you go. So if we look at the sizes of those things relatively, here's the largest one is a bacterium, and it's 1 micrometer, not the largest, largest is down here, tapeworm, is 1 centimeter. Some of these liver flukes, some of these other roundworms, 1 centimeter. So you could actually, if you remember the little clear plastic ruler, I don't know if I got one handy here, I don't, but these smallest designations on the ruler are 1 centimeter designations. You can see these with naked eye. 10 micrometers would be the next one, protozoan parasites like the malaria parasite, and in this case they have a dysentery one, that kind of thing. 1 micrometers, remember there's 1 million micrometers per meter, so this is 10 of those. These are quite small, but the bacterium is 1 micrometer, and a virus is 1/10 of a micrometer. They're very small in size. So that's the range of sizes of organisms that our body has to deal with. And I want to also point out these little spiky protrusions on the virus, on the bacterium, and actually all of these have them. Later we're going to call those antigens. And just nice to have that picture of them right here. And their job is, among other things, to identify that virus. It knows itself. If it has a different antigen there, it will maybe try to attack it. So that's how your body identifies pathogens. All right. So in the notes, we left off with the beginning of the discussion of immunity. We were talking about pathogens. Immunity generally, as it says here, is the ability of the body to defend itself against pathogens of all the sorts that we've talked about. And generally speaking, there are 2 types. There's non-specific defenses that you have and specific defenses that you have. And if you think about ways that you're made that will keep pathogens out of your body, because remember, that's what they're trying to do, is get into your inner self, inside of you, preferably in your bloodstream or whatever organ or tissue that they generally target. What are some defenses that you have that would not require that your body identify that pathogen, but would simply keep out all pathogens? That's what we're looking at. That's what I mean by non-specific. Well, here's some examples. Your skin is a non-specific barrier. If you ever wonder why somebody that gets a severe burn dies as a result of that, one of the reasons is because they've lost their ability to keep pathogens out of the body. Of course, there's shock and fluid loss. That's more imminent, more acute. The oils on your skin. You know you've got oils on your skin if you've ever had to go without a shower or a bath for any period of time. You can feel it all over you. And then the mucus that we sort of despise so often in our nose and respiratory tract and other places, digestive tract. It is an immune defense. It helps keep pathogens out by sort of encapsulating them and getting them out of your body. The acidic environment of your stomach, yeah, it's acidic, and that's what pepsin works best in, and so that's certainly a main function. But that acidic environment also is not very conducive to bacteria taking up residence there. Of course, H. pylori, the one that causes ulcers, is an exception to that. It's learned to live in that acidic environment, but most bacteria don't. And then lastly, on this list is bacteria themselves. You know that you have bacteria in your large intestine that make things that your body wants. Certain vitamins like vitamin K, B5, biotin that we've already talked about. So those bacteria are supposed to be there. You know you've got bacteria in your mouth. We saw them when you did the cheek cell slide. And they're supposed to be there. And they should be there because they keep bad bacteria away by something called competitive exclusion or competitive suppression. The existence of the right bacteria in the right spot on your body keeps bad bacteria off those spots of your body. And so a bacteria-free body is not your goal. Keeping the bacteria numbers appropriate and in the right place is the goal. Some examples of when that's a problem. We've already talked about thrush. Remember that white substance in babies' mouths that they used to put diapers in to combat? That's an example of when there isn't good competitive exclusion and that particular pathogen can take up residence. In your mouth, lactobacillus, that the bacterium that helps your body break down lactose, milk sugar, that helps keep the thrush pathogen out of your body. What is it? Albicans, Candidemia albicans, I think is what it's called. And so that's a good thing. In the hospital, there's so much care taken to make sure that you're not exposed to bacteria in the hospital that it can actually become too cleanly. And if you have to take antibiotics in a hospital, which is common, it may kill off everything else to the point that you become susceptible to problematic bacterium. Like Clostridium difficile is a good example. For short, it's just called C. diff. It's common in hospitals. I had some numbers on that. 30% or 20% of people entering a hospital will become infected with C. diff, and 30% of those will actually develop diarrhea as a result of that. You're supposed to have C. diff in your large intestine, but only in certain numbers, and when it gets into other places, like upper in your small intestine, stomach, mostly small intestine, it can be a problem. The problem with C. diff is even alcohol won't kill it off. So it's a tough problem to have, tough to get rid of. All right, so those would be some physical barriers to bacterium that are not specific. Again, they don't require that your body identify the specific pathogen. They're going to be broad range. They're going to keep everything out. Another one would be if you get a cut on your hand. Help if I have I'm grabbing a mouse for the wrong computer here. That's just not going to work. This is just a generic picture of a cut, obviously. And if you think about what happens when you get a cut, there are certain things. And among them, hopefully, the first thing is pain. We don't want pain, but it's kind of a good thing. If you've ever put your hand on a burner when you were a kid, hopefully not as an adult, you know that the first sensation you had was that it was hot, and you probably burned your hand, and you got your hand off the burner right away. And that was a good thing, because the longer you keep your hand on the burner, the more severe the burn might be. And so pain is a good thing. There was a lady lived down the street from me, actually mowed her lawn, and she had some ailment. I don't know if it was Hansen's disease or what, but she lost feeling in her fingers. And she was also a seamstress. And the problem was she would sew, and on several occasions she actually sewed her hand right to whatever garment she was working on because she couldn't feel it, and had it fairly well sewn in there before she realized that she had better back things out. There actually is an ailment called Hansen's disease. You know it as leprosy. Biblically, there are some very interesting passages that deal with leprosy. So here in, I think it's, no, that's not the right one. I think it's Luke chapter 12, chapter 17, verse 12. It says, now on his way to Jerusalem, Jesus traveled along the border between Samaria and Galilee, and as he was going into a village, 10 men who had leprosy met him. They stood at a distance and called out in a loud voice, Jesus, Master, have pity on us. And of course he healed them, and only one turned back to thank him, and if you remember that story. And then earlier on in Leviticus, let's see, where did I have that? Let me look at my passages here. Leviticus 13:2. See if I can see this well enough without my cheaters. When anyone has a swelling or a rash or a bright spot on his skin that may become an infectious skin disease, which is to say leprosy, he must be brought to Aaron, the priest, or to one of his sons who is a priest. The priest is to examine the sore on his skin, and if the hair in the sore has turned white and the sore appears to be more than skin deep, it is an infectious skin disease or leprosy. When the priests examine him, he shall pronounce him ceremonially unclean, and so on and so forth. So there's a specific protocol for that. Hansen's disease is a specific ailment, and this is what it might look like, a blotchy appearance of the skin. Here's a whitish sore, and that would be typical of the biblical passage. This person has very white hairs anyway, so it would be hard to tell on that one. Here's another look at it. It is still a disease that's around. This is what can happen. Now, leprosy doesn't cause the loss of fingers necessarily, but it does cause a loss of nervous sensation. And so the person might have a damaged or injured finger, and it becomes infected, and he loses that digit because of the infection that he didn't feel, or she didn't feel, and not necessarily because the leprosy ate off the digit. It's a fairly easy to treat disease now. It is still out there. You still see places where it exists. People in some places are still quarantined for it. They're banished to leper colonies, as if you will. But you'll see it a lot in southern areas in the United States. Not a lot. Rarely in southern areas in the United States. And again, it's easy to treat in this day and age. Central Florida, Texas are common places where you might find leprosy or Hansen's disease. And the reason for that can be because of one animal that is sort of the intermediate host, the spreader of leprosy. And that is this one right here, the armadillo. That is a carrier of Hansen's disease. Interestingly enough, it never had Hansen's disease pre-colonization, so evidently we brought it to this country. So if you think back then to this cut, what happens at that cut? The first thing is you get pain. And what happens? Well, in your notes it talks about damaged tissue releasing bradykinin. Actually, it's veins. The walls of veins in damaged tissue release bradykinin, and this causes nerves to fire. I wish it wasn't a beneficial thing, but it is. It gets us away from that thing that caused us injury. It also causes mast cells. You see in your notes, it has basophils in parentheses here. So they're virtually the same thing. They come from the same stem cell. So I use them interchangeably. If you think of that picture that I had, that image I had of white blood cells. Actually, I'm actually going to go back to it. Sorry. And I want circulatory system. I got to go up. And so one of the kinds of white blood cells was a basophil. And if you remember, all basophils, all the phils, basophils, eosinophils, if I can get that here. Oh, shucks. Okay. Oh. Now it's giving me grief. Guess I'll go back to this. They carry these little packets on them that, that help, these little packets right here, that carry things. And so in the case of, exit drawing, my bad. So in the case of white blood cells, maybe go over to basophils here, fumbling around with that. Basophils right here, those little packets carry histamine and heparin. Okay, and so histamine and heparin do some very specific things. We've already talked about them. Histamine is a vasodilator. So a vasodilator means it makes the vessel bigger, allows more fluid to flow through it. And heparin is an anticoagulant. It keeps blood from clotting. All that is there to sort of flush out the wound. It increases the fluid flowing to the wound. It decreases its ability to clot, at least short term. This does not stay in effect, but short term. And all that is there to keep the wound, to allow the wound to flush out any pathogens. So capillaries open. Capillaries open. That's what histamine does. It's a vasodilator. Fluid, proteins like eventually fibrinogen and white blood cells go to the wound area for temporary repair. And then because there's all that fluid and blood there, the tissue reddens and swells. If we look back at that image that I've got there, you can see those things going on. There's a reddened perimeter around this. You can't really see it swollen, but there's likely a little puffiness here. When it was first happened, it would have bled in response to that release of heparin into the area. And yeah, and then also, oftentimes in a wound area like this, it feels to the touch, it feels warm. And that is also something that happens. And that is to make that area, this new window to the outside, this new passageway for pathogens to get into the body, to make it less attractive for them. It increases white blood cell activity to the area, and so basically what that means is neutrophils and monocytes or macrophages move into the damaged tissue. And so this is the image that I want you to think of with that. So here is I'm going to move myself up here just a little bit, get me out of the way. Here is the blood vessel. It's got a tear in the wall, so it's bleeding. Here's the damaged tissue, and out come macrophages, well, monocytes initially, and then they become macrophages, a kind of white blood cell, monocyte is. Neutrophil, another kind of white blood cell. It comes out. There you can see them squeezing through. Squeezing through. And they're going to attack the pathogens then. Okay? So what they're going to specifically do is something called phagocytize. And that's this image that I showed you on Wednesday in class. This is the amoeba surrounding the paramecia. So it extended its cell wall around the paramecium. It injected digestive juices into that vacuole that it created around these two paramecia, and it literally digested them. That's what's going on here. Here, the macrophage, it's surrounding the bacterium. It's just says pathogen, but I'm calling it a bacteria. It'll surround it like the neutrophil is doing. It will send a lysosome with digestive enzymes and inject those into that cavity it's created around that bacterium and dissolve it away, eat it away. That process is called phagocytosis, or to phagocytize is basically to eat a pathogen. And then kind of the last thing here in response to some of these bradykinin, some of these cell signaling molecules that are out there, is there'll be the message to speed up or increase production of neutrophils so that there are more white blood cells going to that wound area. That's all the things that happen when you get a wound and the reason that they happen. This list of 5 items here, very important. Okay, so we're still on this concept of non-specific immune defenses, things that don't require your body to identify the specific pathogen. Number 3 is complement proteins, and your textbook has this picture of the process. And here's a bacteria, okay, and it has been identified as foreign, and in response to that, your body doesn't have to identify the specific bacteria, but it produces these proteins that attach to the surface of the bacteria, drill a hole in it, and pop it or make it explode, if you will. Okay, that's called complement protein, which assists antibodies, chain of conversions resulting in proteins which can destroy the membrane, like I said. It basically put a marker on it to attract macrophages and neutrophils or promote inflammation in the area. But right here, chain of conversions, when I say that, you should think dominoes. Yep, there it is again. I'm not going to play it because I can't. It'll mark this video for removal because it doesn't like it when I do that. So when it says chain of conversions, you think dominoes. The last one here is interferon. When I was but a wee tot, this was first discovered. It's a protein of the immune system, and it was going to cure cancer and the common cold. It was just the best thing since sliced bread. It's still a really good thing, but it is kind of not proven to be the be-all to end-all when it comes to defeating disease that it was initially promoted as. It's a protein that's produced by virally infected cells. So if you got a cell that has a virus that's infecting it, sort of that cell's last-ditch attempt to defeat that virus, and even though it's going to lose the battle specifically, it wants nearby cells to defeat that pathogen. So it causes this protein that is produced by a virally infected cell that's dying, it causes nearby cells to produce a protein that interfere with viral replication. And once again, this is a chain of proteins, think dominoes, just like fibrinogen, that has to have a conversion one to another, and then it produces interferon, which may help defeat that particular pathogen. Okay, so that's non-specific immune defenses. Again, defenses that your body has that don't require that a specific pathogen be identified. Just a little bit of introduction to the next section, and we'll be done. That is specific or adaptive immune defenses. With these, the body does need to identify the specific pathogen and create an antibody that will destroy it. The body is, and so that's why the word adaptive. It's able to adapt to and create an antibody that will defeat a pathogen that has been identified. How does that pathogen get identified, you might ask? Well, because like all cells, they have antigens on their surface. And when I say antigen, think way back to the cell surface. So here's a cell membrane. These are the transport proteins. We talked about some of these being insulin receptors. Well, some of them are also signposts, if you will. Some of these markers on a cell's membrane that identify that cell as either self, belonging to self, or foreign, doesn't belong in the body. So when I say antigen, this is a good thing to be thinking about. A marker on a cell surface, a cell membrane, that identifies it as belonging or not belonging. So antigens, they have to be identified and interpreted, if you will. And then once that interpretation has happened and the cell is identified as foreign, then an antibody will be produced to defeat, to kill off that cell marked as foreign. We've already talked about antibodies. If you remember the proteins that are in plasma, we talked about 3 of them, alpha globulins and goiters. Remember those big goiters on a person's throat? Beta globulins, sex hormone transporters. And then the last one was gamma globulins. These are some of the plasma proteins. They're produced by B lymphocytes. And we've talked about lymphocytes. That was the smallest of the white blood cells. Okay, so if I go back here and fumble around with this a little bit more. Here are the 3 phils, eosinophil, basophil, and neutrophil. These are the granular white blood cells. And then here are the cytes. The monocyte, the great big white blood cell that turns into a macrophage, and the littlest white blood cell, the lymphocytes that are almost all nucleus. Notice there are two different ones represented here. That's because we've already talked about T lymphocytes, those that are produced in the thymus gland, and here I just mentioned B lymphocytes. That's this one here. And they mature in, I shouldn't say are produced by the thymus gland. They mature in the thymus gland. And the B lymphocytes mature in the bone marrow, hence the B for bone marrow. So antibodies are produced by B lymphocytes, and they destroy cells with antigens marked as foreign. Whenever you see antibody, you will see some form of this. This is their shape, an artist's rendition of the molecular structure of their shape. But commonly, they are simply identified as having a Y shape, like you see here. And the ends of them here, this is a portion of a pathogen that's been presented to it. So the blue would be the antibody. The green would be the antigen that's been presented to it. So antibodies are often represented with that Y shape. And that's what we're going to consider. So antibodies, yep. Very good, and we'll probably stop right there, antigens, antibodies, and pick up passive and active immunity, specific immunity, next time we meet. All right, I think I'll stop there.